and branch out a little bit from there. Okay, so schizophrenia, what it is exactly is the criteria would be 2 or more of the following, each with a significant portion of time during a 1-month period, or less if the person was treated successfully during that time period. So you're looking at delusions, which is a fixed false belief in something. Hallucinations could be auditory, which is much more common than visual hallucinations. Disorganized speech, disorganized behavior, negative symptoms, social, occupational dysfunction. These paintings are called the Wayne Katz drawings, and this guy named Louis Wayne, I think was his name. Anyway, he was an artist who apparently had schizophrenia, and the story is his paintings kind of show his descent into schizophrenia and how he viewed his cat. But there's some art critics that argue that that's not actually true. But I think it makes for a good story. So you got kind of a normal cat that looks slightly paranoid, then you've got really odd-looking cats that kind of almost look demonic in the final phases. So kind of maybe some insight into how a schizophrenic might view the world, which is maybe a little bit scary to think about. If that disease took over your mind, how you might perceive your surroundings potentially. And then, schizophrenia joke. Here we go. It's not paranoia if the cappuccino is really out to get you. All right. So schizophrenia is, of course, not as common as depression, but it's still something that affects a fair amount of people. And schizophrenics, unfortunately, it's a very difficult disease to manage and live with, and you end up with a high burden on the healthcare system. So if you work in like acute care psychiatric facilities, you're going to see a lot of schizophrenic patients. Roughly present in about 1% of the population. So again, there's a fair amount of people out there with schizophrenia. Similarly, among all different cultures globally, and similar rates between men and women. Men is a bit more common than women. And there is an age onset difference. So men usually have an earlier presentation of schizophrenia. Usually they'll present in their late teens, early 20s. Women, it's older, so usually slightly. It's usually in the mid-20s to even early 30s is what's more common for women as far as schizophrenia presentation. Suicide rate is really high with schizophrenics. So about 10% of schizophrenics will successfully commit suicide. 20 to 40% will actually attempt, so just massive numbers. Generally, 20% reduction in life expectancy. So not only are they committing suicide more often, they also have a lot of high comorbidities too. And a lot of that has to come with, not necessarily taking care of themselves per se, but there's also a high rate of substance abuse too. So about 75% of schizophrenics are thought to smoke cigarettes. Now, I have read some literature that said that that's not actually true. There were some studies that came out that showed really high rates, but there's some other evidence that shows maybe it's more normal than that. But for the most part, people with schizophrenia do turn to substance abuse, probably at a higher rate than the general population. And cigarette smoking seems to be a common one. There's no known cause of schizophrenia either. There's been a lot of theoretical postulations, specifically genetic links. So if somebody has a family history of schizophrenia, it's more likely to have it, but it's not a guarantee. There's been looks at anything from like vitamin D deficiency. So there's an interesting correlation somebody found at one point where babies that were born in a certain month, meaning that their mother would basically have been having late gestation during the winter months, so maybe early spring or late spring, early summer, meaning that you might have lower vitamin D exposure as a mother, and then that might contribute to it. Anyway, these kind of like half-baked theories come out, but nothing really is for sure. But that did actually show a higher incidence of schizophrenia for people born during certain months of the year. All right, so prodromal phases, acute phases, stabilization, and stable. I'm not totally concerned you know this, but basically people usually kind of have a gradual onset, and then all of a sudden they're isolated. They have a significant deterioration of hygiene, especially for young adults during this phase of their life. They're usually high school or college students when this develops, so it's all of a sudden you have an athlete who was a great student who's now not coming out of his room and hasn't showered in 3 weeks and is isolating and is super paranoid. That could be, what you might see as a progression into schizophrenia. Acute phase usually accumulates in some sort of a full-blown psychotic behavior, and a complete lack of an ability to care for oneself, which could manifest in a suicide attempt. Stabilization, so we really want to make sure that these patients are getting stabilized and medicated as soon as possible. Psychotherapy has a place in schizophrenia, but medication is primary when you're looking at these really intense psychotic symptoms. Once people are stable on a medication regimen, you would consider that symptoms mostly or completely gone. You may have some residual mental health issues, so depression, anxiety are common. So you see these patients get on other types of medications too. So they might be on an SSRI in addition to their antipsychotic, just like our treatment-resistant depression patients might be on an antidepressant in addition to their antipsychotic too. So it kind of all comes full circle, and there's a lot of things that are tied together within mental health. So we use a lot of the drugs for a lot of the same things. Okay, so with antipsychotics, there's two major groups. There's atypical and typical is what they're called, but it's easier to remember first generation and second generation. So atypical or typical antipsychotics are actually the first generation, atypical are the new ones. But think of second generation as the newer ones, first generation as older ones. It's a more common term now. So before these agents existed, we had really nothing to do for these people. There was all these half-baked theories like actually, ECT is still used, so that's not a half-baked theory, but insulin coma induction, so people would decrease people's blood sugar to a point where they're going into a coma using insulin. A lot of people died from this. Didn't really help. Lobotomies, which of course aren't done anymore either. So those were some theories that they tried. Otherwise, people were getting locked in mental institutions. There wasn't much you could do for somebody with schizophrenia until we had medications. We actually just still use ECT or electroconvulsive therapy. We do it in very controlled environments, and it is a highly effective approach to treatment-resistant, not only schizophrenia, but also depression and bipolar disorder. We do a lot of it at Abbott, and I've observed several cases for a number of reasons, and it is quite interesting. It's all done under anesthesia, paralytics, and everything like that, but they do induce a controlled seizure, and they're trying to target a certain wavelength for a certain period of time. So there's psychiatrists that specialize in doing that, and they've studied, how much of a seizure people are responding to, and so they have all this documentation of what they're doing, and there's an anesthesiologist there making sure that the sedatives are all done correctly. So it's very controlled. It actually isn't scary at all. Somebody just lays on a table, gets sedated, and they put some electrodes on their head. You hear a buzzing noise. They kind of convulse a little bit, and that's it. So it's not like what you'd see in the movies per se, but it is similar. So it's kind of a barbaric older technique, but again, it is quite effective still. Usually they do a couple of weeks of course of ECT, and they'll reassess after that. So usually it's like a certain number of treatments for like 2 to 4 weeks, and they'll see how that goes. Yep. And usually there are medications involved too. Occasionally they get people who are salvage and they're off all their meds, and that's the only thing they're going to try. But usually after that course, you can get some nice long-term benefits from that. So this chart, of course, I don't want you to know any of this really, other than to know that this is what all the different receptors these drugs hit. So these drugs are really dirty, especially the second generation. So all these drugs, except for the bottom two, are second generation, haloperidol and perfenazine. If you look at haloperidol, which is kind of like the typical first generation antipsychotic, it's very heavily on its dopamine targeting. So they're mostly, for the most part, they're dopamine antagonists. And there's thought to be schizophrenia is associated with a dopamine over-response in certain areas of the brain. In a lot of ways, it's kind of the opposite of Parkinson's disease, which is why when you antagonize the dopamine receptors, you get some of those types of symptoms, some of those movement disorders. So when we have haloperidol, a drug like that that's older, it's primarily just working on a variety of dopamine receptors, where our newer drugs working on a lot of different serotonin receptor subtypes in other areas of the brain. We'll talk about why that's a little bit more important here in a second. So with dopamine, you have different parts of the brain that have hypoactivity and probably different parts of the brain with hyperactivity. So there's imbalances. And so the mesolimbic pathway has hyperactivity, which is causing our positive symptoms. So there's an overexpression of dopamine, which is causing your things like hallucinations and delusions. Mesocortical is all about hypoactivity causing some of the negative symptoms. So negative symptoms are things that you would expect a normal person to have that just aren't there. So like flat affect's the most common thing you can think of with that. Meaning that you're just kind of flat. You don't have a lot of tonation in your voice. You don't really express emotion very well through your verbalization. Other things like just poor cognition, things like that too. And then there's the pathway, the nigrostriatal pathway, which is all about motor control. So this is where our dopamine agents for Parkinson's disease would focus on treating the deficiencies there. Now, when we give drugs that block dopamine receptors, what we really want to do is target this mesolimbic pathway, but kind of a casualty comes by with blocking dopamine receptors and other pathways in the brain, which is why the biggest side effects with the first generation antipsychotics are Parkinson's-like movement disorders, like our extrapyramidal symptoms that we talked about with antiemetic drugs and tardive dyskinesia, which we'll talk about a little bit more in a second. So the newer drugs focus on, they have a little bit of dopamine activity, but they also have heavily active in antagonizing certain serotonin pathways. So it's thought that there's some sort of an overexpression in some serotonin pathways that's causing mood, memory, processing, and sleep cognition issues. And whereas with depression, we're trying to increase serotonin in certain parts of the brain, in this part, we're trying to actually antagonize those receptors and block those receptors. So very different pharmacology. Different, again, just think about it, it's different parts of the brain having over and under expression of different hormones. Okay, so these are the major receptors we're looking at, and I'm not going to get too in-depth on this on a test. What I want you to know is kind of the general difference between a first generation and a second generation. But this just to highlight all the things that these receptors do and all the things that these drugs play around with, that they just aren't simple. So you have dopamine receptors that can get movement disorders. Serotonin receptor manipulation can cause nausea, sexual dysfunction, and weight gain. Alpha receptors can cause hypotension. Histamine receptors, sedation and weight gain, can increase appetite. That's a big problem with some of the newer antipsychotics, is people gain tons of weight. There's a couple that are really nasty for that. And anticholinergic. So there's a lot of these medications that borderline or are at least heavily anticholinergic. So again, if you're curious and want to like map things up, you can see. Okay, so what drugs are heavily active on the histamine receptor? Well, olanzapine and clozapine are. Those happen to be the two drugs that cause the most weight gain. What drugs are heavily active on the muscarinic 1 receptor? Clozapine and olanzapine, again, also heavily anticholinergic drugs. So you can think about it, and then of course, what's going to be more orthostatic hypotension, more alpha activity. So that's it. And I have a better chart that shows side effect profile, which is, I think, this next one here. There it is. So if we're looking at side effect comparison, you can kind of see where side effects fall. And the only thing to really think about with this is why we like picking certain drugs over others. So for example, olanzapine causes so much weight gain. It's one of the gold standards as far as second generation antipsychotics. It's highly effective, but people can, there's reports of people gaining like 100 pounds on olanzapine. And it's not a metabolic thing that it's altering. It's not just really to increase your appetite. So if you educate a patient on this, that they're to portion control or have a caregiver portion control for them, you can maybe avoid some of this, but it can be really challenging. But a drug like aripiprazole or Abilify, for example, doesn't really have a major side effect profile to speak of, which is why it's a really popular drug, not only as an antipsychotic. It's kind of a weaker antipsychotic, so maybe not the best for like pure schizophrenia. However, people love aripiprazole as an adjunct for treatment-resistant depression and treatment-resistant bipolar. That's why Abilify was like one of the top 5 most prescribed drugs in the country as far as sales go for the last several years, until it recently went off patent. So really, really popular medication. Again, we're looking at limited side effect profiles here. For example, a drug like lurasidone or Latuda is a newer medication, pretty limited side effect profile too. But the idea with them coming out with newer equivalents of these is we're limiting the side effect profile, but we also need to retain the efficacy of these drugs, which can be challenging. So a drug like aripiprazole just isn't as good at treating schizophrenia as a drug like olanzapine. But its side effect profile is better. So you get this catch-22. So can we meet in the middle somewhere? And that's where drugs like risperidone might be a little bit better, and lurasidone, some of the ones we're going to talk about here in a little bit more detail. Just to review this, I know we talked about this during antiemetics, but this is really where this becomes a huge issue, is the EPS and tardive dyskinesia. So extrapyramidal symptoms, again, movement disorders, Parkinson's-like movement disorders, akathisia, dystonia. And it's really associated with acute antipsychotic use. It's usually high doses of first-generation antipsychotics are going to cause this. However, you can see it with a number of things. So, like we can go back and see EPS-TD here. You notice the first-generation agents, it's much higher than the second-generation agents, which is a key as to why we like second generations as a class much more than first. So first-generation antipsychotics are rarely used first line anymore. They might have some utility in acute phase care, but for chronic management, we don't like them, and that's primarily because of this movement disorder issue. You'll see some of the newer ones have them, but overall as a class, it's much less prevalent. And then tardive dyskinesia can really occur whenever you're on the drug. You could have it 6 months, you could have it several years out, and people will just develop an involuntary facial movement, usually some sort of lip smacking, tongue movement. It's kind of like a jerking. I did a couple of psych rotations as a student, and I saw a few people with this, and yeah, it's kind of this distracting where they just kind of lick their lips or stick out their tongue odd every so often during a conversation. You can also have extremity movement, but it's more common to be facial related. And this is usually an irreversible side effect, unfortunately. Okay, so I want to go through these pretty quickly because you're not going to see them all that much as far as first generations go. And again, that high EPS risk is why they've fallen out of favor. They are effective. There have been studies that show that they are as effective as our newer drugs at treating schizo-related symptoms. However, they just aren't as good at side effect management. Now, we're trading off some side effects for another, but generally speaking, people can't tolerate EPS and tardive dyskinesia as well as you can tolerate weight gain. If you want to take that as a trade-off side effect. So for people who might not respond to a second-generation drug, these could be a good drug, but for the most part, they've totally fallen out of favor. Haloperidol is probably the exception here, and while it's not used chronically, it's really nice for acute symptoms. It's highly sedating. It's very effective, and so if you have somebody who's acutely agitated, they're endangering themselves, they're endangering medical staff. This is a medication we use fairly liberally, and it usually controls the symptoms immediately and it sedates people. So this is something you'll see given maybe an acute phase while they could transition to a more stable long-term regimen. There is a long-acting form too, so sometimes people get this as well. It's like a every 2 weeks injection. And you still run the risk of the movement disorders, but it's delayed. It kind of provides a steady stream into the blood, and it's a little bit more better tolerated. But people on chronic Haldol, it's very unusual, and it's really considered the very typical first generation. So it's a dopamine antagonist, and that's really what it does. It doesn't have a lot of activity on other receptors. Some other first generations. These are just some examples of things that can be used. And again, there's this big trial out called the Katie trial. When all the second generations were new and shiny and brand and expensive, they did this trial called the Katie trial where they looked at, well, are we wasting our money? Why are we spending all this money on these new drugs when we have old drugs that might be just as good? And sure enough, they found perfenazine was actually just as good as all the new second generation antipsychotics. Problem is that people had high EPS risk on them, and so people were discontinuing them or they're being switched because of side effects more frequently than they were from the second generation. So ultimately came down to side effects and side effect profile taking precedent over side effect profile. So they decided the extra cost was worth it with the newer drugs. Now fortunately, most of the new second generations have gone generic, so they're relatively affordable now. And there's a couple other ones, like just some fun facts. Chlorpromazine's old first generation that they used for hiccups, irretractable hiccups. You might give somebody that. Okay, so if you're going to give somebody Haldol to calm them down, what do you do in that situation? To prevent you can try and prevent EPS, and what we're going to usually do is a combination of an anticholinergic medication. Usually we give Benadryl. It works very well. There's another one called benztropine, which I don't think I have on here, but it's a more it's a less sedating version of the same effect. Really, it's just an anticholinergic med. Oh yeah, benzotropine's on there too, cogentin. And it's usually combined with a benzodiazepine too, so they'll give it with lorazepam a lot as well. That's not only to add on to the sedative effects, but it also does help prevent some of the EPS as well. And we'll talk about psych emergencies in a little more detail during emergency medicine, so I'm going to kind of gloss over the emergency aspect of this disease right now. All right, so moving into the second generations that are much more prevalent and talking about them maybe in order of how they're used, but it's a little bit nebulous when you get to these. So risperidone is, a lot of people would consider this to be the most popular initial antipsychotic, and it's for a number of reasons. First of all, it's inexpensive, it's generic, it's quite effective, and it also has a relatively tolerable side effect profile. It does have some dose-related EPS, and maybe more so than any other second generation, but at normal doses, it's pretty well tolerated. And it also has kind of the unusual side effect of causing hyperprolactinemia, which can cause breast development in men, and some other side effects like irregular menstrual cycles and things in women. But for the most part, it's a pretty decently tolerated drug. These drugs are not clean by any means as far as their use and their side effect profiles and how many receptors they hit. So if we can get by with a couple side effects, we're relatively happy. It also comes as a long-acting form. So anytime you're treating people with advanced mental illness who don't necessarily have a good social network set up to help them, long-acting forms can be really beneficial. So if you can get somebody in your clinic once a month and give them their medication then, you don't have to worry about them taking pills on a daily basis. So a lot of times in the hospital, we might start somebody on risperidone. It works. We give them a shot, send them on their way, for follow-up. But at least we know that we don't have to worry about them taking their medication every day if they don't have a good support system in place. And paliperidone's kind of a me too, so it's Invega. Paliperidone's still on patent, but it's got a long-acting form that's once monthly versus the risperidone form is every 2 weeks. So that's just a little bit more convenient and actually ends up being about the same price. So for once a month versus twice a week. Both are not cheap, but a good option for some patients. And certainly way less expensive than having somebody non-compliant leave your hospital and come back in 3 days later because they didn't take any of their meds. Olanzapine. Olanzapine or Zyprexa is, again, considered to be probably the most effective second-generation antipsychotic when it comes to treating both positive and negative symptoms well. A lot of drugs don't test themselves when they come to the market against anything. So the problem with antipsychotics is it's really where the FDA has kind of allowed them to approve their drugs by testing them against placebo. Well, that's ridiculous. I mean, of course, if you test any antipsychotic to a schizophrenic patient versus placebo, hopefully it's going to work, right? Otherwise, what's the point? But they don't prove themselves. They don't have to prove superiority to current standards of care, which is a little bit unusual in the drug development world. So you see these new drugs come on the market. It's like, well, yeah, you're superior to placebo for 8 weeks. Congratulations. Like, anybody who can mix chemicals together and come up with like an adjunct of one of these drugs can probably do that with a drug company and a chemistry background. It's really not all that impressive. What we get more impressive is when they're testing them actually and putting them up against olanzapine. So if any drug company is willing to take the plunge and try and test it against olanzapine, that's a bold move because usually they're going to come out as the weaker of the two. However, it's about looking at where you are. So it's difficult to prove superiority to olanzapine, but if you can prove non-inferiority, that's pretty good. So again, that's what we're looking at for literature is like when we're looking at these newer drugs coming out, we don't care about them unless they can say, are you better, at least the same as a current agent available. And olanzapine's a good example of just being very effective at schizophrenic symptoms. However, the problem with it is it causes so much weight gain and metabolic disturbances via that weight gain. So it increases diabetes risk, substantially increases hypercholesterolemia, and those things are just poor tolerability, which is why it's fallen out of favor a little bit as a first-line agent. It does come in a lot of different forms. It comes as an orally dissolving tablet, which is great for people who like to cheek their meds, spit them out. Comes as an IM shot, which we can give in acute situations. It also comes as a long-acting medication as well. Okay, Seroquel is another one of the original second generations, and it's a weaker affinity compared to a lot of the other drugs. And so if you see somebody on Seroquel for actual schizophrenia, they're going to be on really high doses. However, what you see Seroquel used for a lot more is low doses for either mild agitation. So it's a really popular drug for elderly patients with dementia. I think I mentioned it there a little bit. But as an antipsychotic, it's a bit sedating, and it seems to calm people down, even if you give really small amounts of it to people. Especially elderly people tend to be heavily affected by it. So if you give like almost a dose that most of us probably wouldn't even notice if we took it, they use it as needed for agitation in elderly. I've also seen people use it as needed just as a sleep aid. Wouldn't recommend that as a first-line choice, but you see it sometimes used for that as well. And then for psychosis caused by Parkinson's disease, it seems to have the best results in giving that to patients to treat that side effect of those drugs as well. Very low incidence of EPS, which is another reason why we like it for those Parkinson's patients. And so really when you're looking at Seroquel, you might see it used for pure schizophrenia, but it's getting a lot of use for other indications and diseases here and there. Geodon or ziprasidone is a drug with a pretty good side effect profile. It doesn't cause any weight gain. It's also a little bit activating. Most of these drugs fall in the sedative spectrum, I would say. This one does not, which could be good. If you have a patient who has a manic component to their schizophrenia, which we call like a schizoaffective disorder, that can be problematic because it could induce that a little bit more. But if you have somebody who's generally sedated or maybe a little bit, has been sleeping a lot, that's something that could help them out there. It is generic. It gets kind of a bad rap because it prolongs QTC, but quetiapine and another drug called iloperidone, which is a newer medication, are pretty much the same. So it's just another one of those medications, kind of like citalopram, that there's not a whole lot of risk with prescribing it, but if if you do, you just want to monitor and make sure you aren't stacking up multiple QTC prolonging agents. It does come as an IM form, so you can give it acutely for people, which is always nice to have those options. And it also has some interesting like serotonin, norepinephrine reuptake inhibition, like an antidepressant would. So it could help treat some of those depressive symptoms as a one-shot medication. So this is another one that's actually quite popular as an adjunct therapy for bipolar adjunct for treatment-resistant depression. Good side effect profile. Maybe not the greatest antipsychotic in the world, but it's also quite effective at some of these mixed diseases, presentations, or resistant mental health illness. Yeah.
Just like looking back here, so does it have like a lot of alpha activity? I thought it was like side effect profile.
I'd have to look.
Okay. I was just wondering if there's a lot of blood pressure.
I mean, maybe some mild orthostatic, but it wouldn't be.
Plus.
The one you'd really be worried about is probably, well, elaperidone, which isn't a very common one, but we're going to talk very briefly about clozapine, which is kind of on its own island. That would be the one that's got the biggest issue with that. Okay. And then aripiprazole or Abilify. Again, this is a big seller, recently generic, and the reason is what I already said. This is a drug that's used as one of the most popular adjuncts. So you'll see it used all over the mental health spectrum, and that's why it's gotten so incredibly popular. And it's a very well tolerated medication. Usually, what we see, if anything, you do see some EPS at higher doses, and that's probably the only side effect that's generally reported with Abilify. Now that Abilify went off patent, the company came up with brexpiprazole or Rexulti, which it was tried against placebo and got approved. So it's perfectly legal for them to do, but no one knows if it's any better. So I honestly don't see a whole lot of use getting out of it, but you never know. Okay, and then this clozapine patient case, just for time's sake, I'm going to kind of skip it. And clozapine's something that it's just it's an oddball drug that is very interesting. But I'm just going to give you the nitty-gritty of it. So basically, I spent some time at the St. Cloud VA, and there is a woman there who's tried essentially every antipsychotic under the sun. I'll show you all of her history here. So she's been on a number of first generations, a couple, and 2 first generations and 3 second generations, all at pretty high doses there. And she was non-compliant. She had treatment-resistant schizophrenia. So that's where clozapine comes into play. Clozapine is a really old second generation. It's probably one of the first second generations developed. And actually, when it was developed, it got pulled off the market immediately because its biggest side effect is neutropenia, and even more so agranulocytosis. So clozapine, because it causes this at a relatively high rate, it's still quite rare to actually see it. Clozapine got put back on the market with all these restrictions. So there's this program that anyone on clozapine has, whether you're a prescriber or a pharmacy dispensing it or a patient on it, you have to be registered with the national registry, proving that you're getting labs done every month to show that your ANC is not getting below a certain point. And if you can do that, then you can stay on clozapine. So there's all these different restrictions for it. And if you want to go through this and look at some more of this, I just don't think this is all that relevant, since I'm not going to test you on this. Clozapine's got a whole slew of side effects that are pretty nasty. It's probably one of the worst tolerated from a side effect point of view. It's heavily anticholinergic. It's very sedating. It causes a ton of orthostatic hypotension. If you can ramp somebody up and give it at bedtime and get around some of that, again, it's a really, really effective antipsychotic, which is why it's still on the market. So the question is, with all this monitoring, when you initiate therapy, you have to monitor somebody weekly for 6 months, and then if their blood counts stay within this range, then you can move on from there. But it's a very interesting drug from the standpoint where there's not really anything else like it where we do this much work. There's a couple things similar, but this is very interesting as far as how standardized it is across the country, and what we're doing to prevent agranulocytosis. So of course, if you get that, your immune system is essentially shot and you're at risk for tons of opportunistic infections. So yeah.
Just kind of curious, how willing are the patients to go on a medication like this, or they have to come in weekly for lab draws?
Yeah, that's a good question.
Or if they're at that point, they have like no other options.
Yeah, they probably have no other options, and these patients are likely not in charge of their own healthcare. They're probably in a group home. They might have family making decisions for them. So there are a lot of actually legal things to get into, which I'm not going to, but there's you can actually get court orders to force people to take medication. So a lot of our psychiatrists will have to go to court to testify for patients who say, no, I'm not taking clozapine. Like, well, you can't really function without it, so we have to have you on it. And they'll have to go and testify. They've tried everything else, and we need clozapine at this point. Yeah. All right, so yeah, there's all these guidelines for how you do it, but again, I don't really care. So anyway, this lady, she did actually really well, but the point of this story, which is kind of fun, is that her ANC dropped really low. So 1,000 is pretty much the cutoff for not being able to be retried on clozapine. And so they gave a drug called lithium, and lithium is used for bipolar disorder, which can actually boost white blood cells and ANCs a little bit as a transient effect of its mechanism. And so they gave that to her, and she was able to get a little bit of augmentation of her therapy from that drug, but it also was able to keep her on clozapine, which is the only drug that worked for her. I have seen a few patients who have dropped really low on clozapine, and they've actually re-challenged it. So it is possible, but you have to go through a lot of paperwork, and that's risky to do. So anyway, she ended up doing really, really well at the end of the day. And she lived on her own. She was leading a relatively independent lifestyle. She had a job and everything. So it's kind of just the point of the story is that when you have mental health disorders that are complicated and resistant, you've tried everything under the sun. Sometimes these older drugs that are dangerous actually work really well for patients. And clozapine's not all that uncommon in the world of schizophrenia. So if you work in that with those patients, you might see it from time to time. Yeah.
I'm curious. So I took care of people with schizophrenia, and a lot of them were on clozapine, and it seemed like their psychiatrist would only give them weekly doses of clozapine because you always have to change it.
Yeah, that's not.
Does the blood work change that much?
Yeah, it depends. So if they're getting a big fluctuation in their ANC, it can definitely change what they're doing as far as the prescribing goes. I think a lot of the time is that the side effect profile is what is the biggest deal, especially when you're ramping up. So clozapine titration takes a long time to get to an effective dose. I mean, you're talking about, well, it depends on how fast they do it. But you start off really slow, and most of that's due to the orthostatic hypotension being really severe. You give a high dose or therapeutic dose of somebody clozapine right away, they're going to pass out pretty regularly. So that's mostly the slow titration. So that could be what you're talking about. As far as messing with it, maybe the patient wasn't stable. I'm not sure. It's hard to say. But you do see doses titrate a lot with psych medications. And the therapeutic range, I've seen people on a couple 200 a day to up to 900 a day of clozapine. So it's a big dose range that you could play with if you were a psychiatrist trying to manage somebody. So maybe you're decreasing other medications and increasing clozapine to see if you can get them just on that. So yeah, it's a lot of playing with medications as psychiatry. Yeah.
Just curious, was she failing these other meds because it wasn't controlling or because of the side effects?
Part of it was non-compliance. She just wasn't taking them. And the other part was mostly, when they even tried risperidone long-acting, it still wasn't working for her. So the one long-acting option that was available at the time, which was a while ago, wasn't effective enough for her to sustain her side effects or symptoms.
So get to this point of the hospital usually because all these other, they're just not controlling.
You have to try a number of things. Yep. It could be some side effect related, but usually it's lack of efficacy from the other agents. Yeah. Yes. This is a national program. Yep. The company used to be in charge of it, but now the government's taken it under as this, which actually is nice. They streamlined it really, really well. Okay, just some quick other things. New agents. I just have one slide on the new agents because they're new. They aren't used all that much. Pretty much it's the same concept. You can see I've incorporated them into those other charts, the side effect profile and the receptor bindings, if you want to look at that. But with drugs like these, you're getting variable use. So brexpiprazole and cariprazine are the newest two. I've never seen them used. Latuda is probably the most popular one. And it's interesting, they actually studied this in some pregnant models and actually got a category B on it. It's only antipsychotic with that on there. It's extremely well tolerated. It has one of the best side effect profiles out there. And Latuda markets themselves as being pro-cognitive. They say they target some additional serotonin receptors that help restore cognitive functioning better than other drugs. Whether that's just bogus drug company jargon, or if it's actually true is yet to be seen. But they do have some preliminary testing, some in animal models and some small trials in humans showing that maybe there is a cognitive benefit of Latuda. So as far as these new medications that have probably come out within the last 5 years, Luracidone is by far the most popular. And this is going to be the big money maker as far as adjunct use too. This drug, you've probably seen ads for Latuda on TV, and it's advertised heavily for treatment-resistant depression and bipolar as well, but it is traditionally an antipsychotic. So it does have those mixed mechanisms. That's going to be the next Abilify as far as the money maker for sure, if it's not already. All right, so is there a perfect antipsychotic? No. You'd want a drug that decreases your positive and negative symptoms. Most drugs we have on the market are good at decreasing positive symptoms. The negative symptoms, maybe, maybe not. That's a bit more challenging to bring those back to a normal level. Cognitive functioning is the other problem. You can maybe get by with no symptoms or minimal symptoms, but is the person able to is their brain restored to a functioning where they can hold a job or they can live on their own? That can be really challenging. And a lot of times these patients, even if they can be managed on an antipsychotic to prevent psychotic outbreaks, they might not be able to function in society like a normal person. So they end up in a group home or with relatives and care and stuff like that. So it's unfortunate, but our drugs, there is no perfect thing, and they all have side effects. There's no pure drug that's just going to help everybody with this condition. So it's a lot of monkeying around with different adjuncts too. So you add on mood stabilizers, you treat bipolar components, you treat depressive components of it too. So you end up with a lot of different things going on at once. And then of course there's economic considerations too. So some of these medications are expensive. Psych patients, if you guys haven't heard, psych patient beds are at a premium in the cities. We regularly have people boarding in our emergency department, anywhere from I'd say 2 to, I think one morning I came in on like a Saturday and there are like 14 psych patients waiting for beds throughout the metro. Once you get to an emergency department with a psych reason, you can't be transferred out legally, so you're stuck there at that hospital until a bed can find. Well, sorry, they can't transfer you like to a non-psych facility. I mean, so you can't just like put somebody in a med surge bed or find somebody, send them to another ER somewhere. So you have to stay controlled. I mean, you can close your ER briefly, but it's a really big deal and issue. So there's all this problems. There's all these problems in the community with psych access, and getting drugs on board and getting drugs titrated is very complicated. So you can see how this all compounds everything. And so it's very challenging, but we do the best we can with the tools we have. All right, so just to review and talk about like where we might start. So basically, you're going to start with anything but clozapine. You never start somebody on clozapine, and you generally don't start somebody on olanzapine. Olanzapine could be like a second line option if somebody's not responding well to the first one, but we avoid it just because of that weight gain issue. Insurance may dictate which agent to use, but most of them, other than that slide of newer agents, they're all generic, so they should be mostly covered. We always do cross tapers with switching, so you're going to titrate. You're going to taper off while you titrate up on another drug at the same time. You can use 2 second-generation antipsychotics at the same time, so the mechanisms are slightly different. You might see people on 2, not terribly uncommon, especially with more treatment-resistant cases. And then combination of adjuncts, again, antidepressants, mood stabilizers. Treatment-resistant, clozapine's kind of the role there, and then non-compliant, those IM products can be really helpful in those patients too. Some pregnancy and lactation stuff, just throwing this in there. You have minimal risk with both first generation and second generation antipsychotics, believe it or not. But some studies show increased rates of blank. I didn't finish my sentence there. I think it was just general congenital malformations like cleft palate and maybe some cardiogenic stuff. But you can finish that sentence however you want, I guess. It's like Mad Libs. So you don't. But the point is that there isn't a lot of literature out there. Usually what we're looking at as far as danger comes from multiple psychoactive medications combined. Quetiapine does have the lowest rate of placenta passage. Olanzapine haloperidol the highest. Does that make a difference? Generally speaking, when we're looking at like a pure schizophrenic patient, unless things are going really well for them, they probably should. Well, I don't like to say things like this, but it's very challenging to be in a pregnant situation as a schizophrenic patient. I mean, the odds of you being controlled or not in an outbreak or a schizophrenic exacerbation can have a devastating effect on the developing fetus. So it's very challenging. Of course, there's a lot of ethical considerations there too that I'm not going to get into, but it's an unusual case to see that, I should say. What you're going to see more commonly is second generation antipsychotics uses adjuncts for people with depression or bipolar who are maybe considering families, not necessarily the pure schizophrenic patients. neonatal toxicity and withdrawal. And again, lactation data is almost non-existent, so we don't really talk about that. That's that. All right. Perfect timing almost. Any questions?